What's a cranial nerve? All right.
I think she said a stroke.
Uh-oh. All right, let's start with Bell's palsy. What is Bell's palsy? What is it? Facial nerve, is it upper or lower?
Lower.
Lower. So what happens to someone with Bell's palsy? Droopy mouth, what else? And eye. Droopy mouth and eye. What else do they have besides the muscular issues on that side of the face?
Sensation.
What kind of sensation? Okay. Taste. What? That one little tiny spot on the ear is the only real somatosensation issue. Because what is sensation on the face? Trigeminal. So we have that little spot in the ear if you want to go for that one. Taste. What else?
You can't move your eyes.
Blink your eye. Blink your eye. Because moving your eye is what? Right, 3, 4, and 6. So oculomotor, abducens, and trochlear. Okay. But the blink is 7. So closing it. So what else? What about some of the visceral motor things? What did the guy in the video complain of? Dry eyes. So what would we prevent dry eyes with? How do you make clear eyes? You buy drops. You can all use drops. Or maybe you make your own drops, like tears. Okay, your lacrimal glands and your salivary glands. That's not for your eye, that's for your saliva. So with Bell's palsy, you also have visceral motor issues. You have problems with making tears, problems with salivating. You've got special sensory issues, the taste. What's the other cranial nerve for taste? Oh. Well, go through the names, and you might be able to figure it out. Glossopharyngeal, yes, because that's the tongue, and taste is on the tongue. I heard somebody guessing hypoglossal, which might be a good guess, but it's wrong. What does hypoglossal nerve do? It's also with the tongue, and since I've already told you it's not taste,
It's movement.
movement of the tongue. So if I were to damage my actual hypoglossal nerve on my right, what would happen? My tongue would deviate to the right. What would my tongue look like? Which side? The right side would be atrophied. Exactly, because my hypoglossal nerve is what part of the cell? Like every nerve is. Well, not every nerve, yes, is a lower, well, it could be sensory too, but if it's motor, it's lower motor neuron. But it's an axon, right? So the hypoglossal nerve is the axon. Where's its cell body? In the brainstem somewhere. Okay. Probably which section of the brainstem? Medulla. It's in the medulla. Because remember, they go rashomatoddle. So the hypoglossal nucleus is in the medulla. It's got the cell bodies, and its axon is the hypoglossal nerve. So if I damage that, I will have lower motor neuron problems ipsilaterally. Well, how would I have an upper motor neuron problem with my hypoglossal? Where would my damage be then? Where?
Opposite side?
Opposite side where? Yes?
It crosses, so.
Give me a place. You know, lots of neuroanatomical names now. Contralateral side in the something, in the something, in the something. Geographically, where in my brain might I get a upper motor neuron lesion?
Medulla?
Precentral gyrus.
Precentral gyrus. That would be a good spot for my upper motor neurons. Remember, we've got the whole tongue sticking out of the homunculus? That's where they are. They're in the precentral gyrus. Those are cell bodies. Then where are its axons? They are the tracks. Where do they go? somewhere it's got to get from my precentral gyrus to my hypoglossal nucleus, which is in my medulla. The axon's going to go where? Where do they go? They always go the same place. They've been going in. No, they don't go to the thalamus. They come up to the thalamus. Internal capsule. That's a good spot. What do we call these tracts that go from the cortex to the brainstem? Thank you. What do we call the tracts that go from the cortex to the spinal cord? Right. So why would we call the ones going to the brainstem cortical spinal? That wouldn't make sense, would it?
Something spinal.
No, bulbar. Bulbar. Cortico-bulbar means they go to the brainstem. You guys have been studying this really hard, haven't you? What's more important?
Neuro.
Thank you. Come on. All right. So we got through a little bit. Let's go through a really fun one. Let's go through the 8th cranial nerve. What is that? That's half of it. Vestibulo. You got. It's actually 2 nerves. The vestibulocochlear nerve is actually 2 nerves: a vestibular nerve and a cochlear nerve.
Credit, Kelly.
We're giving you 50% there. All right. So let's start with the cochlear nerve. What's its function? This is easy.
Balance.
Hearing.
Auditory. Hearing. So if somebody has a deficit, they would have a hearing loss. And what's the other thing that we often have?
Tinnitus. Ringing in the ears.
Ringing in the ears or tinnitus, exactly. So that's our cochlear component. And the other part,
That's balance.
that's the balance one. That's the vestibular nerve. Okay? And so what's a big reflex? So the VOR, good. The vestibulo-ocular reflex. So what is my stimulus for the VOR? What? Movement of the head. Say it confidently, you're right. Movement of the head. And then my afferent. Cranial nerve 8, so vestibular nerve, exactly. And then what? Where's it go? It's got to go somewhere. Vestibular nerve, it's got to go somewhere.
Vestibular nuclei.
What?
Vestibular nuclei.
Yeah, that's a good one. Vestibular nuclei. After the vestibular nuclei, then where? Well, we'll talk about cerebellum in a minute, but it doesn't go to the cerebellum for this. The MLF, the medial longitudinal fasciculus. We've got to get you guys confident in your answers. So it's, all right, I move my head. My vestibular nerve detects it. Whoa, move to the right. Comes into my vestibular nuclei, goes up the MLF to where? To where? No, we're not going up to the gyrus. This is a reflex. We don't need to go up to the cortex. The cortex is for thinking. We don't need to think about our reflexes. What happens when I turn my head? What's the VOR?
Oh.
Ocular motor. So that's where it's going to go to the 3 oculomotor nuclei, which are which, and which?
3, 4, and 6.
3, 4, and 6. And what's my response going to be?
Eyes are gonna follow your gaze.
Tracking?
Follow it?
No, opposite direction.
Opposite direction.
Oh, yeah.
So as I move my head, like if I'm trying to maintain gaze on the back of the room, as I move my head to the left, what happens to my eyes? They go to the right. Doll's eye. My eyes move in the direction opposite my head. That's the reflex. What's the function of that? Why do I have this reflex? I'm doing it all the time. My VOR is working right now, like crazy.
Maintain gaze.
Maintain gaze, because what would happen if that wasn't going to happen? What would happen as I just walk across the room? Well, my world would be moving, just like a really bad video. So these patients with vestibular issues are like watching a really bad movie the whole time. And do they ever do that in movies intentionally? What was the movie that was recent?
Blair Witch Project.
Oh, and it's,
No, Cloverfield.
I saw another one recently. Oh, Hunger Games.
Oh, yes.
Yes.
Oh, who was sick at the beginning of Hunger Games? They did that so intentionally. They messed with our VOR because they basically didn't have that vestibular input to come and move our eyes. So instead the world moved, and so how did you feel? Really sick. Because when we have a mismatch, it goes to our reticular formation and makes us very nauseous. So people with vestibular issues tend to be nauseous, and have symptoms of vertigo and all the other stuff. Yeah, VOR was hard. The cerebellum, I know I heard that. Cerebellum, what's its link to all of that? Any idea? I haven't gotten into too much depth about it, but who does the cerebellum connect to both ways? A whole lot. The pons to get to who? It's coming into the olive. Well, we'll eventually go there, but the big thing is all the both in and out of the vestibular nuclei. Cerebellum and the vestibular nuclei are like best friends. They talk all the time. And the cerebellum turns up the VOR and turns it down. So that means that people with cerebellar issues also have the same similar problems. Okay. All right. Well, let's try another one because you're doing so great. I'm kidding. Cranial nerve 6. This is easy. What's it do?
Abducens.
Abducts the eye. So it's the abducens nerve. It abducts the eye. So somebody with a deficit will have what? What? Diplopia. And what do we actually see? What's the real? What?
The leg rotate.
Oh, that's, you see that more with trochlear, but it's the same idea. It's strabismus. Strabismus is a lazy eye, where the eye just doesn't match. We had our first week of peds, and I swear we had a contagious strabismus. Every kid, all their eyes. And so you guys should have all come down and go, now I got it. Of course, the second year, so I'm like, do you see anything that might be an issue for the person? No. Do you think that they can see? Maybe that's going to cause a little problems with standing. Yeah?
So the vestibular nuclei, it goes to the, is it part of the cuneo-cerebellar tract? Because that's when it's like subconscious and...
The cuneo-cerebellar tract, can anybody tell her what that's carrying?
Subconscious proprioception.
Proprioception. So, no, the vestibular is actually going to be the balance issues. So it's going to actually, and we'll talk about the vestibular system, but we're basically talking about tilting and spinning of the head is what the vestibular nuclei detect. Versus the proprioceptive system, which we're going to get into a lot of depth today if we get past the cranial nerves. So why don't we talk about 11? Who's 11?
Accessory.
What? It's the pretend one. It's the social climber. Because where is cranial nerve 10's nucleus?
It's in the brainstem.
It's not in the cranium at all. It's in the spinal cord. All right?
You mean 11?
I meant 11. Did I say 10?
Yeah.
11. See, you guys are so smart. You caught me. 11. I'm sorry. 11. I was thinking of 11, and I must have said 10. So, cranial, yeah, 10 is in the, you were right. That's in the medulla. But 11 is in the spinal cord, and what does it do? Upper traps and sternomastoid. So, spinal accessory, not cranial accessory nerve. That's the spinal accessory nerve. But it does come out, it comes up and it goes out by cranial nerves 9 and 10, so we'll give it a little status. All right, that was wonderful. I'm crossing my fingers that we will get those a little bit better. Megan. What?
My stomach just made a whole lot of noise.
What cranial nerve might that be? Vagus. Good, see you got that one. Gosh. All right, now we're going to go to the spinal cord. So we're going to really talk, the spinal cord is going to be in the next several lectures, but we're essentially going to talk today about the actual kind of overview of the structure and function of the spinal cord, and then we'll move on to the somatosensory pathways going through the spinal cord, and then the motor pathways, both within and without the spinal cord. So we'll kind of cover all that, and then at the end of all that, we're going to take a break from lecture, and you guys are going to do the work and figure out lesions and what will people present with various lesions of different areas. So this is just the first really looking at the spinal cord. So big functions for the spinal cord. They're going to be receiving sensory information, so somatosensory and viscerosensory information. So this is going to be tactile information. It's going to be proprioceptive information coming up through the spinal cord, going up to the cortex, or maybe not even to the cortex. It's also going to carry all the descending systems that are going to influence our lower motor neurons. So our spinal cord, again, is going to have tons of pathways going up and down, sensory and motor. The innervation of muscles, so we're going to have our lower motor neurons that are going to directly innervate the muscles on the same side of the body. We're also going to have our visceral motor neurons innervating our smooth muscles and our glands. And then this other one is our spinal reflexes. And so a couple things. The spinal reflexes are certainly going to have many survival functions. And they're also going to give us a lot of indication about the integrity of the spinal cord. So many of our actions are going to be reflexive in nature, which means it's not voluntary. It didn't come from the cortex, but it was in response to some type of sensory stimulus. So if I step on a hot coal, would I like to take the time for that pain and temperature to go up through my interlateral pathway, go all the way up to my somatosensory cortex, and then go to the association areas for me to go, wow, hot coal, that's really bad. I might want to take my foot away. Would that be very logical? No, what would we like to happen? We want to take it off quickly. We want it to happen reflexively. And so a lot of what the spinal cord does is reflexive in nature. Could I use my cortex to keep my foot on that hot coal? Yes, so we often do inhibit our reflex activities with our cortex. You can inhibit your DTRs, and some people have a hard time not inhibiting their stretch reflexes. All right, so just remember with development, essentially we started with just an alar and a basal plate for dorsal and ventral. Basically, they were motor and sensory on the surfaces, but when it actually develops, the dorsal side of the spinal cord is going to be our sensory side for the most part, and then the ventral side is going to be our motor side. So through development, it really does kind of keep those orientations, and much better than it does in the brain or in the cerebrum or in the brainstem. So in the spinal cord, dorsum is sensory, and the ventral, at least in the gray matter, is all motor. Just as a review, again, we've got our conus medullaris in an adult being around L2. Remember, in the child, where is it? What? Well, in the newborn, it's the entire spinal column, and then as they grow, so it's lower, for essentially, depending on the age of the child. We've got our filum terminal, again, just not actually depicted in this picture, but it would be meninges just attaching to the sacrum. And we've got our cervical and lumbar enlargements, because why are there both cervical and lumbar enlargements?
Plexus.
What?
The brachial.
The brachial plexus, or the neurons whose cell bodies will form the brachial plexus, and then, or their axons will, and the same with the lumbosacral plexus, just because the number of neurons that we need to supply the muscles in the limbs versus the muscles in our trunk. So we've got our cauda equina again, which is just after the end of the spinal cord. All of the nerve roots for the lumbar and sacral levels are going to exit together and enter together. So with a cauda equina injury, what might I expect to see? What? Give me a motor symptom. Paralysis. What kind of paralysis?
Flaccid.
Flaccid. I wasn't sure I heard the ah sound. It wasn't spastic, I hope. It's flaccid because these are lower motor neurons. These are the nerves leaving the spinal cord. So you'd expect a flaccid paralysis with atrophy and fasciculations and all that. Now, we don't have the same number of vertebrae as we do nerves. So the roots for C1 through C7 actually exit above the vertebra, and then below that they're going to go below. when we look at a cross section of the spinal cord, we have fissures just like we do in the cerebrum. We've got our ventral median fissure or our anterior median fissure, which is the deepest. And if you remember in the lab, we could recognize this because of the anterior spinal artery that goes down the middle of, or goes right through the ventral median fissure. So we have that. We have a dorsal median sulcus, which divides the two sides of the dorsal columns. We have a dorsal intermediate sulcus, which is here. We only have this above T2. Why do we only have a dorsal intermediate sulcus above T2?
More sensation.
What do we not have below T2? Fasciculus cuneatus, because where does fasciculus cuneatus come from? The upper extremity. So remember in our dorsal columns, we've got our fasciculus gracilis and our fasciculus cuneatus. And so below T2, there's only gracilis. So that's why we don't have the dorsal intermediate sulcus. We have dorsal and ventral lateral sulci, which is where the dorsal roots come in and where the ventral roots go out. And then we've got, obviously, the spinal nerves. The blood supply to the spinal cord is actually pretty straightforward. We've got the anterior spinal artery, which is huge. That's going through the ventral median fissure. And that supplies the anterior 2/3 of the spinal cord. So all of this. So that anterior spinal artery supplies everything except the dorsal columns. We have posterior spinal artery on either side supplying the dorsal columns. But again, the anterior 2/3 of that spinal cord is supplied by one blood vessel. Remember that the spinal cord is organized segmentally so that we have our dermatomal levels, our myotomal levels, and our sclerotomal levels. Again, this is going to be ipsilateral innervation. It's going to leave the spinal cord or enter the spinal cord from that side of the body. In general, we're going to have the white matter surrounding the gray matter. We're going to have the spinal nerves arising from the roots. So the spinal nerves are going to contain sensory fibers that will go into dorsal roots, and ventral fibers or motor fibers coming from ventral roots. And we have the rami, which we're not really going to get too into, except that they're mixed. Well, the roots are either sensory if they're dorsal or motor if they're ventral. So here we're just adding in to our picture our dorsal root and our dorsal root ganglion. So this is all what kind of information? Okay, and then here's my ventral root, which is the axon of that lower motor neuron, also known as an anterior horn cell or a ventral horn cell, because the cell body's in the ventral horn. So this ventral root contains motor or sensory? Motor. And then, again, we've got our rami, which I don't care that much about, to be honest with you. But then we've got our nerves, which contain the motor component and the sensory component. Actually, while we're here, we'll go into it in more depth, but a couple other things that we just want to point out as far as structural. We've got the central canal of the spinal cord, which contains cerebral spinal fluid. Okay, obviously, it's right in the middle of the gray matter. And the only thing I want to point out at this point is that there are fibers that cross from one side to the other. So if these are actually axons, what color are they? White. Okay, and where are we? Are we in white matter or gray matter?
Gray.
Gray. So there's actually, within the gray matter of the spinal cord, there are axons going from one side of the spinal cord to the other. So we actually have a white commissure in the gray matter.
What's the point of that?
We are going to get into that, but it's where our pain and temperature fibers are going to cross.
Okay.
What else? Why else would we want one spinal side of the spinal cord directly communicating with the other side at the spinal cord level? What reflex?
You're burning your hand.
Or if I step on that hot coal and I step on it on my right side, why would I maybe want to go to my left side of spinal cord to have some other type of reflex activity? So it would catch me, because otherwise what will I do? Fall. So I might want to have what we call the crossed extension, which is, ooh, I better extend the other leg or I'm going to fall over. And that's one of the things that white matter does.
Is that the reasoning behind like the carryover effects, like, or crossover effects, like when you strengthen one side, it's supposed to help?
That actually is more believed to be at a cerebral level. But it's true that we have neuro overflow. So, and we'll talk a lot about next year. But some of it does happen at the spinal cord level, but a lot happens at the cerebral level also. So when I activate one side, the commissurals will go. That's a good way to treat. So here's just another view, again, looking at sensory coming in and motor coming out. Here's my deep ventral median fissure and my not as deep dorsal medial sulcus. Here might be my dorsal lateral, and I have my ventral lateral sulcus where my ventral roots are leaving. All right, the gray matter, again, it's named by various areas, but we've got our dorsal horns, which are going to have the afferent information, the sensory information coming in. The main area that we're actually going to talk about is the substantia gelatinosa, which is one region of the dorsal horn. I don't need you to identify it, but just realize it's in the dorsal horn. Then we've got our ventral horn, which is going to be our motor neurons, our lower motor neurons. Then we've also got in the thoracic and upper lumbar regions, we have our intermedial lateral horn, which is going to have the preganglionic neurons for our sympathetic nervous system. So these are going to be our visceral motor efferents. And they're between T1 and L2. So if you look at the spinal cord cross-section between T1 and L2, we'll have very small ventral and dorsal horns because we don't have a brachial plexus or a lumbosacral plexus. But then we'll also have this intermedial lateral horn, which is containing, again, the cell bodies for our sympathetics, preganglionics. And then we've got right in front of the central canal is where we have that white matter, and we call this our anterior white commissure. And it's where fibers are crossing from one side of the spinal cord to the other. This is going to be some of our reflex actions like you were talking about. And then it also carries pain and temperature. We'll look a little more specifically at that. So in the ventral horn, I've pretty much at this point kind of made it sound like all we've got is lower motor neurons. And that is a lot of what we've got. But we also get those lower motor neurons. They get information from all different areas. So one of the places that they get information is from the upper motor neurons, from those long descending neurons coming from the cortex, or maybe from the red nucleus in the brainstem. Okay. We've also got information coming from dorsal root neurons going directly to those lower motor neurons. We'll talk about them, so that's for reflexes. And then we also have a lot of interneurons in the spinal cord as well, which are regulating those reflex responses, but also being involved in controlling the lower motor neurons. So if you actually look at the ventral horn, here's my lower motor neuron. Okay, you see that it's got influence from the, well, here's our direct. This is our direct dorsal root coming. So this is our monosynaptic stretch reflex that we'll look at. Again, dorsal root coming in, touching base with it. We've got information from the cerebrum, from the corticospinal tract coming and touching it. And then we've also got the local interneurons controlling it. So basically there's lots of different influences on what that lower motor neuron will do. So it's sensory, it's from the cortex, from the brainstem, and then also interneurons. So a Rexid lamina just really should be review. Is the numbering system for the gray matter within the spinal cord. And the only region I really want you to be familiar with is substantia gelatinosa. That'll be important when we talk about somatosensation. So you should be able to look at a cross-section of the spinal cord and figure out where you are. We talked about the cervical cord being largest because it's got a lot of white matter, and it's also got a lot of gray matter. And then when we get into the thoracic cord, we have very thin ventral and dorsal horns. We still have a lot of white matter, but then we have the intermediate lateral horns. Then when we get into the lumbar region, we get more gray matter, less white matter, and no more intermedial lateral horns. And then when we get to the sacral level, we have a lot of gray matter and very little white matter. Yep.
This might be a stupid question, but it looks like lumbar has a lot more white matter, and then sacrum, like the sacrum looks like it has a lot more.
The lumbar region looks like it has more white matter than what?
Well, didn't you say that?
Well, actually, in this picture, white is gray and gray is white. Isn't that unfortunate? Sorry. The white areas are actually gray. Bad picture, I guess. But this is how it would show up if you looked at it. And then the black is actually white. So we should just do a negative of this picture, I guess. Does that help?
Yeah.
Sorry. You're right that the white is. So the center areas are actually gray matter. When we talk about these dorsal, and I'm not going to talk too much about, I don't really care that you know which ones are medial and which ones are lateral, but what I want you to know is that the fibers coming in through those dorsal roots are actually organized topographically. So remember we talked about some fibers are myelinated, some are not myelinated, some are larger, some are smaller. So in the lateral portions of the dorsal roots, these are our fibers that are very lightly myelinated or maybe even not myelinated. And then in our medial portions of our roots, these are our heavily myelinated fibers. These are very fast fibers. I missed it. Okay. But again, just what I want you to see here is that, all right, what happened?
I sneezed very obnoxiously. Not on purpose.
So what cranial nerve might that be?
Olfactory one.
It's 5 or 10.
It's actually associated with the cough and gag, sneezing. So like
Awesome.
9 and 10 go together for that.
Yeah.
Yeah. So actually, like infants don't have a really good cough, so they'll often sneeze to clear rather than coughing. Anyhow, I thought that would make you feel better. But anyhow, the big point here is look at the different fibers coming into the dorsal roots. They're going to be organized by the type of information that they're carrying. And so we're going to have some fibers very lightly myelinated, slow moving, and some fibers heavily myelinated, fast moving. Which ones do you think would be slow and which ones do you think would be fast? What do you think is being carried by our slow fibers?
Pain.
Yeah, why would that be? I don't know. What would be carried by our fast fibers?
Proprioception.
Proprioception. Mm-hmm. It'll be helpful later on, but for now I don't know why that would be. But it'll help us. All right, so once they come in, what I want you to see in this picture is that depending on the type of information and the type of fiber that comes in the dorsal root, they're actually going to travel differently in the spinal cord. Okay, so for example, our very heavily myelinated fibers carrying proprioception, they're going to actually come in and go straight up through our dorsal columns, while those that are going to carry pain and temperature, they're going to cross almost right away in the spinal cord to the other side. So they're actually going to have different pathways depending on the type of information. So not only is this information organized topographically by the type of information, whether it's pain and temperature or proprioception and deep pressure, but also somatotopically. So actually within the ventral horn itself, we actually have regions that are more extensors and more flexors for that particular segmental level. So this will probably be more useful as a picture of essentially the way that the ventral horns are organized. What you'll notice is that the axial musculature is actually going to be more medially, okay? And then, so it's proximal, more medial, and then distal, more lateral. And then you've also got our flexors, more dorsal, and our extensors, more ventral. Yeah, so like this. Big thing is that we could damage one part of the ventral horn and end up with different muscles being involved. So not all the segmental level goes to one particular group of muscles. So for example, for biceps, what myotome level is that? C6? Some of us have some C5. Some of us has more C5 than other people's. Our myotomes vary person to person a little bit. So it's not like every single biceps fiber is only at C6. Wouldn't that be nice if it was, but it's not. So they're a little bit mixed up. All right, then as far as looking at the white matter, at this point we've talked about the dorsal columns. We've talked about the lateral columns, or funiculus, which contains our corticospinal tract. We haven't really talked about the ventral columns, which we'll talk more about. And the ventral columns actually also contain corticospinal fibers, but these are our ventral corticospinal fibers. They go more to our axial musculature, so more to our trunk and our neck. So in the spinal cord, we've got the long ascending fibers, which are our sensory fibers that are going up to our thalamus and beyond. We've got our long descending fibers that came from the cortex or maybe from the brainstem. I talked about the red nucleus. What tract is that? Rubrospinal. What else in the brainstem might go down the spinal cord and be a long descending fiber? If I were falling, what? The MLF is a local one. There's ascending and descending, but you're in the right kind of area. If I was falling, what would detect me falling? Yeah, so would I want some information maybe going from my vestibular nucleus to my, yeah, wouldn't I like that? Because what might I like to do if I'm falling? I'd like to catch myself. So I have vestibular nuclei sending information, reticular nuclei sending information. There's several brainstem regions in addition to the cortex. Those are our long descending. And then propriospinal basically are going to be fibers that are going to connect multiple levels of the spinal cord. So these are interneurons within the spinal cord that might connect, for example, let's say L4. What is the muscle for L4? Quad. What about S1? What?
Yeah.
What about S2?
Hamstring.
All right. What do you have for tibialis anterior? What? No, we haven't gotten there. All right, well, we'll get. All right, I was trying to get what have you done, the upper extremities and not the lowers yet?
Yeah.
Oh, that's why I'm like, okay, you're not quite with me here. All right, let's do uppers. All right, it's a little harder in uppers, but that'll work. What's wrist flexion?
7.
Okay, I'd go with C7. What about elbow flexion? This one you just said. Okay.
6.
So there's 2 different levels of the spinal cord. Might I ever want to do this? Right? And might I want to do this reflexively? So I might want those regions of my spinal cord to communicate, right? So that I can have a functional synergy to pull my arm toward me or to pull that object toward me. So I can have wrist flexion and elbow flexion in a reflexive manner. These propriospinal neurons basically are going to communicate between multiple levels of the spinal cord so that we can have several joints working in synergy. So that I can have wrist flexion with elbow flexion, so that I could have dorsiflexion with hip flexion and knee flexion. So if I'm pulling my foot off of that hot coal, it would be kind of a bummer if I had hip flexion with knee extension. That really wouldn't work very well, would it? I'd like to have hip flexion, knee flexion, and dorsiflexion, right? Because plantar flexion, that won't help me either, right? Because that brings my toe closer to the coal. So I want some functional synergies that are going to work. And so that's what our propriospinal neurons do, is that they communicate between the spinal cord levels so that they can work together in a functional manner. And then commissural fibers are going to be the fibers that communicate between the two sides of the spinal cord. So we're going to go through this picture thousands of times. But if you look at the white matter of the spinal cord, our dorsal columns, our lateral columns, our anterolateral columns, and even our ventral columns, they're all going to be carrying specific topographic information. We've talked about dorsal columns carrying 2-point discrimination, proprioception, vibration, deep pressure. The lateral columns being our lateral corticospinal tracts, so that's voluntary movement. The anterolateral columns carrying our pain and temperature up the spinal cord. And now today we introduce the ventral column, which is going to be motor, mostly to the trunk, and axial musculature. So if you look at the various regions, cervical, thoracic, lumbosacral, and coccygeal regions of the spinal cord, we're going to have various distributions of somatosensory and somatomotor, and visceral sensory and visceral motor. The big thing is that in the thoracic and upper lumbar is when we're going to have all of those sympathetic influences. Where are parasympathetics going to be?
S2 to S4.
What? S2 to S4 in the spinal cord, and where else? Because I wasn't even going for there yet. What? Cranial nerves is our other big one. Right, so that's why that's not in there. But in the cervical cord and then the lower lumbar, we're pretty much all somatic. All right, reflexes. So a reflex is a stereotypical involuntary response to a stimulus. So every reflex, like all those cranial nerve reflexes, has a stimulus and a response. And the idea with a reflex is that most of them have some type of survival or building block sorts of purposes. Okay, and sometimes that's hard to imagine what they are, but sometimes it's very easy. There's a lot of belief that these reflexes are building blocks to more complex movement or complex patterns as we develop. They don't require learning. We don't have to learn any of these particular reflexes. And it's believed that these reflexes prime us in some way for function. Some, again, are more obvious than others. So, for example, if, let's go with a primary reflex. If I stroke the chin of an infant's cheek, or the cheek of an infant, lightly stroke it, what does that infant do? Newborn. They don't smile. They
Turn their head.
They turn their head, and that's called rooting. Why do they turn their head? For feeding, right? So it's a survival mechanism that if something's touching my face, it must be about to feed me. So let's turn to it. If I put something in an infant's mouth, what will they do? Suck. So the stimulus is putting something in their mouth, their response is sucking. So most those make sense. They're kind of survival in mechanism. So some of those primary ones are very sensible. Some of them are a little bit harder to understand. So for every reflex, we've got our stimulus. Should be it before that, I guess. The receptor that's going to detect the stimulus. We've got the afferent neuron that's going to send the signal into the nervous system. We've got an efferent neuron that's going to have the cell body that's gotten synapse from the afferent neuron. We've got its efferent axon going to its effector, so the muscle or gland that's going to have the action. And then we've got its response. So for every reflex, we should be able to complete all of this. Now, many of our reflexes also have interneurons mixed in to somehow regulate, enhance, this reflex, depending on what it is. So we've got segmental reflexes that are going to happen just at that level of the spinal cord or just that level of the brainstem. We've got our supraspinal reflexes where we're going to actually control it from the cortex. And then we've got our intersegmental reflexes where many segments are going to work together. So one example is the flexor withdrawal, where I'm going to be lifting my leg away from that hot coal, and I'm going to have several segmental levels involved in that to have hip flexion, knee flexion, and dorsiflexion all work together. So here it is, just our typical reflex. Again, we've got our stimulus being detected by a receptor, being sent in from a sensory neuron, most often acting on an interneuron to our effector neuron or efferent that's going to act on some type of muscle or gland. So the interneurons are going to be how we really modify these reflexes. So when I, for example, do a deep tendon reflex, my patellar tendon, what's my response? I'm going to extend my leg, right? So it might also be a nice thing if I inhibited my hamstring, right? So an interneuron might go to my lower motor neuron of my hamstring to inhibit that. Because what will that do to my knee extension by inhibiting my hamstrings? It will increase it. It will magnify that response. So we have lots of interneurons doing things like that that are basically increasing or augmenting the response and making it more effective. The other big thing is that we do have a lot of both brainstem and cortical influence on reflexes. So your level of arousal will certainly influence your response. So your flexor withdrawal response, your deep tendon reflexes, you can control them by the level of arousal and your cognitive or cortical input. So when we get more complicated than just a simple reflex, which is just stimulus and response, we start to call these reactions. So reactions are not as typical or as stereotypical as a reflex, but they are still automatic in nature. And so most of the reactions we're going to talk about are going to be postural reactions. So again, these are not going to be as stereotypical, but we have them all the time to regain our balance, to maintain our balance, and so forth. Okay, so let's start with our receptors. So I like this cartoon, so I'll let you read it. So the reason I put that there is because this is the functions of our proprioceptors. Our receptors that are going to detect basically muscle length or tendon length and changes in that. Because this is going to give us information for how long our muscle is, so that tells me if my, in my biceps, if my bicep is really stretched out, that tells me my elbow's extended, right? If my bicep is very contracted, it tells me my elbow is flexed. What about the tendon? What would tension on the tendon tell me? Yeah, why?
Protective mechanism.
Might be protective, because what might happen?
Stretch you apart and tear.
You might tear it. It's going to give me an indication of force. So what the load is. The greater the load, the more tension there is of my tendon. So I get an indication from these proprioceptors not just about position, but also about force. So when we're talking about proprioception, it's really feeling the movement. It's feeling the force, it's feeling what direction and how fast. So proprioception is the sensation of body position and movement using, and it should say joints, not joins, sorry, sensory signals from the muscle joints and skin. So we're going to be detecting position, movement, and force. So it's a combination of all of that we're going to get from proprioception. So our receptors are going to be our muscle spindles, our Golgi tendon organs, and our joint receptors. So here we are looking at them. We're not going to really talk too much about the joint receptors, but we are going to talk about the muscle spindles, which are found within the muscle belly themselves, and then the Golgi tendon organs, which are found within the tendon. So the muscle spindles are found in parallel with the actual extrafusal muscles. The extrafusal muscles are the fibers of my biceps, the fibers of my triceps. So those are the extrafusal muscles. And then the Golgi tendon organs are really going to be really at the junction between the muscle and the tendon. So instead of being in parallel with the muscle fibers, they're in series. So let's look at the muscle spindle first. So the muscle spindle itself, and hopefully some of this is review, is made up of muscle as well, and this is called intrafusal. So the intrafusal muscle is the muscle or the contractile unit of the muscle spindle, which is a receptor, versus the extrafusal muscle, which is the contractile muscle of the larger muscle, like the biceps or the triceps or the quadriceps or whatever you're talking about. So here's our muscle spindle with its intrafusal muscle within the muscle spindle, and again it's in parallel with the extrafusal muscle. So within the muscle spindle, it's got both a motor and a sensory component. So it's got muscle fibers that can contract, and it's also got sensory fibers that are going to detect how much it's contracting. And it's really important that you see that they are in parallel. So as my biceps contracts, that smushes my muscle spindle, doesn't it? So it also contracts because it's in parallel. Now, one of the things that we'll talk about is that in order for that muscle spindle to be working, it can't get too smushed. It's got to keep a certain amount of, let's say, basal length so that it can constantly detect how much that extrafusal muscle is contracting. So we'll look at that in some detail. But the big thing that we're going to detect with a muscle spindle is static position. So how long is my muscle? And then the second purpose is dynamic position. Which way and how fast is my muscle changing length? So not only do I know that my elbow is at about 90 degrees, but I know that it's extending and I know that it's flexing. So the two parts of the muscle spindle, one tells me static position and one tells me dynamic. We call our static position position sense, and we call our dynamic kinesthesia.
What was the first one?
Position sense. But you might have a patient who has good position sense or poor position sense, and they may have good kinesthesia or poor kinesthesia. So you have to actually determine, is it that they don't know where they are in space, or is it that they don't know which direction and how fast they're moving? Because they're really regulated by different parts of the muscle spindle and the different pathways as well. So the static part is where I am in space, and the dynamic part is what's the rate of change of that muscle. So to detect that, everything has two parts for the muscle spindle. And I'm not going to get into too much detail. You might think it's too much detail. But we have nuclear bag and nuclear chain are the two types of fibers, intrafusal muscle fibers, that are going to detect static versus dynamic changes. We have two sensory fibers, our 1A and our 2s. And then we have two types of motor neurons, our alpha motor neurons and our gamma motor neurons. Okay, so here's our muscle spindle. Again, we have two types of sensory fibers, our type 2s and our type 1As coming out. We have two types of motor fibers, our alpha motor neuron, which is going to go to do what? What's our alpha motor neuron, also known as our lower motor neuron? It's going to contract the extrafusal muscle. And then our gamma motor neuron, which we'll talk more about, is going to contract our intrafusal muscle. So the nuclear bag and nuclear chain is just the skinnier fiber compared to the nuclear bag. Essentially, the nuclear bag is going to be sensitive to changes. This is going to be more dynamic. Nuclear chain is going to be less dynamic. but essentially together, and I don't care if you know, I just want you to know there's 2 types of muscle fibers, and we're detecting 2 types of information. We're detecting static, which is position sense, and dynamic, which is our kinesthesia, our velocity. The 1A is going to be our dynamic sensory fiber. So this is our kinesthesia. So this is telling me how my muscle length is changing, how fast and in which direction. That's the 1A. And then the 2 is going to be my static. So that's just telling me what the absolute muscle length is at that point. So again, our 1As are going to be the dynamic rate of change. I'm moving quickly, I'm moving slowly, I'm moving into extension, I'm moving into flexion, and 2s are going to be static. Then these are the cool ones, I think. So we talked about the alpha motor neuron. The alpha motor neuron is going to my extrafusal muscle to contract it. Whenever I send a signal from my alpha motor neuron, within my ventral horn, I have another set of neurons called gamma motor neurons. These gamma motor neurons are going to go to the poles of the intrafusal muscle to contract them. So, my alpha motor neuron comes in, contracts my bicep, my quadricep, whatever. If I were to have a gamma motor neuron, it would just squish my intrafusal muscle too, right? If I just squish my intrafusal muscle, it can no longer detect changes. In order for it to be an effective muscle spindle, it's got to have a certain amount of basal length. It has to be taut. Okay? So as it gets squished, it no longer, so that means if I'm at end range of biceps, if my muscle spindle, if I didn't have the next piece, my muscle spindle wouldn't be able to detect where I am in space, because it can't do that if it's all squished up. So, luckily, we have a gamma motor neuron that also gets activated, and what that does is it contracts the poles of the muscle spindle. So that keeps the muscle spindle sensitive. So the bottom line is, why do we have gamma motor neurons?
Keep it from being squished.
What?
Keep it from being squished.
To keep it from being squished. So functionally, what does that provide us? Proprioception throughout the range. So regardless of how contracted my extrafusal muscle is, I can tell you, yes, I'm all the way at end range elbow flexion. Well, it would be easy at elbow extension, but regardless of where I am in my range, I can still detect position sense and kinesthesia because of those gamma motor neurons. So every time an alpha motor neuron activates that muscle, the gamma motor neurons say, oh, gotta keep you sensitive. So it's constantly keeping those proprioceptors, those muscle spindles, ready to detect information. So the bottom line, again, to maintain the sensitivity of that muscle spindle so that the person can know where they are regardless of how contracted that extrafusal muscle is. So again, its functions are to tell us where we are in space and how we're moving. Another function is the stretch reflex. So what'd you guys call it in histo? Did you call it the DTR? Did you call it the MSR? What'd you call it?
Both.
Everything you wanted.
Yeah.
There's a lot of camps that we should call it the monosynaptic stretch reflex because it's got only one synapse. Deep tendon reflex, that's a little bit of a misnomer because the deep tendon reflex, why is it called that? Because you hit the tendon. Where is the receptor?
Muscle belly.
In the muscle. So the deep tendon reflex implies that it's something to do with the tendon. But why do we hit the tendon? To stretch the muscle. So some people really don't like the name DTR, even though you'll never find a chart that doesn't say DTRs on it. So so you'll hear them all. It's all the same thing. So, but essentially it's a stretch reflex because we're stretching the muscle. That's the stimulus. The stimulus is stretch of the muscle, not tapping the tendon. Okay, tapping the tendon is not what activates the muscle spindle. Stretching the muscle activates the muscle spindle. Now, what that muscle spindle does and what that phasic stretch reflex does throughout the range is it allows for a dampened contraction. Because otherwise, if we were constantly activating this stretch reflex, we would have spasticity. We would have just an out of control contraction. So it really does tend to smooth out our muscle contractions just throughout the range. So that's one of its functions. We use it for clinical testing. Really, the purpose of the clinical tests that we're doing with a monosynaptic stretch reflex or a deep tendon reflex is to evaluate that segmental level on the ipsilateral side of the spinal cord. So we're looking at that segmental loop. Does the ventral root come in and the dorsal root come out at that segmental level? So it tells us the integrity of the segmental level, that segmental level of the spinal cord.
So how's hyperreflexia mean in upper motor neuron lesion?
Because that's a very good, so if I tap the tendon and I stretch the muscle and it's hyperreflexic, what does that tell us about the segmental level?
It's not inhibited.
It's not being inhibited. It says it's intact because we had the response. So it tells us it tells us that it's intact, that the afferent is coming in and the efferent is going out. The fact that it's hyperreflexive means that my cortical inhibition of it is not active.
Okay.
If I tap the tendon and get no response, what does that tell me?
Hyporeflex.
It's hyporeflexic. Now, it's lower motor neuron. It could theoretically be a sensory issue. It tells us that something in that segmental loop is not right. That segmental level of the spinal cord is not functioning. Yep.
So you're saying that like everybody is different and certain level they vary on different people. So if
Myotomes do.
but not these reflex. Like, because there's some people that are really hard to get the reflex, and is it because it's different?
It is a little bit because of the differences in the lower motor neurons in each person's level, but more often it's because of our either overability or underability to regulate it by our cortex. Like some of us can just not relax. Okay, and so when you sit there, you do the Valsalva, you do all these other things to regulate the level of arousal of the nervous system. So that's more often what it is. So basically, we're going to test the segmental level with the monosynaptic stretch reflex, and we're also going to have that stretch reflex be part of all of our autonomic postural responses. So by knowing, oh, I'm falling a little bit too far this way and so forth, the muscle length changes, it's going to contract that muscle that just stretched so that I don't move too much. Because if I was standing here and just kind of going all over the place, you guys would be like, huh? Right? Now it might be a cerebellar problem, but it might also just be the way I'm able to maintain this is because I'm detecting with my muscle spindles all those very subtle postural changes and keeping myself still. So those automatic postural things. So some terminology, and we'll use this with several different reflexes. The homonymous muscle is the muscle that contains the receptor that was activated. So when I do a patellar tendon tap, my homonymous muscle will be my quadricep. So it contains the muscle spindle that got stretched. Synergist muscle, for example, this example is in the biceps, it would be the brachialis. So something that also flexes the elbow. The antagonist obviously is going to be the opposite action. So we're going to have, with all of these reflexes, we're going to have interneurons that are going to inhibit the antagonist, and we're going to have interneurons that are going to activate the synergist. And then just looking at the muscle again, we've got our receptor being our muscle spindle coming in through our afferent, through the dorsal root, to the ventral horn, and my efferent. So this is just one synapse. Now remember, when we come in through the dorsal horn, we've got lots of different information coming in. Where is this information coming in? What type of fiber is coming in from the muscle spindle? we talked about, is it fast information or slow information? It's very fast. Remember, these are our heavily myelinated fibers. So these are our 1A afferents. They're coming in. They're very heavily myelinated. They're going to come in really fast. And they're going to go straight to my alpha motor neurons or my lower motor neurons to contract that homonymous muscle. So our monosynaptic stretch reflex, the stimulus is stretching of the muscle. The stimulus is not tapping the tendon, okay? Because tapping the tendon is just the clinical thing that we do to test it. But throughout movement, the stimulus is just stretching the muscle. That's what's going to activate my muscle spindle, which is going to send in signals through my 1As, and then it's going to, well, 1A and 2 really, depending on the movement. And then it's going to go to my alpha motor neuron to contract that homonymous muscle. Pretty straightforward. But then we get a little more complicated. Along with this, we have reciprocal inhibition, which is depicted here. So here's my 1A coming in. Not only does it go to the alpha motor neuron of my homonymous muscle, but it also goes to an inhibitory, and most interneurons are inhibitory, interneuron to go to the alpha motor neuron of my antagonist muscle. So here I'm activating my quadriceps, but I'm simultaneously inhibiting my hamstrings. So that's reciprocal inhibition. So if you were to record this on an EMG, when I do a stretch, a deep tendon reflex, or I tap the patellar tendon, I should see an increase in activation of the quadriceps and a decrease in the hamstrings. All right. In addition to that, we also have sprouts coming off of the 1A afferent to the alpha motor neurons of the synergist muscle. So this reflex, although the essential reflex is just monosynaptic stretch reflex, pretty straightforward, there's collaterals that go for reciprocal inhibition and also for activating the synergist muscle. So we should see with a stretch reflex activation of the synergist and inhibition of the antagonist. So this is a Coke, okay? For those of you who are wondering what's going into the beer mug, it's a Coke, okay? But what the point of this is that we tend to think of like, oh, this muscle spindle, it's just the stretch reflex. And that's true, it is the stretch reflex, but it's not just the stretch reflex. It's something that we need to use throughout daily activity. So as we hold this mug, okay, and we pour Coke into it, what does it do to my biceps?
Increase force.
It exerts force, which what does it lengthen it, or it lengthens the biceps. So if I want to hold that Coke up, what do I need to do? I need to contract the biceps more. So in everyday activities, in order to maintain position, we're using our stretch reflex, our monosynaptic stretch reflex, because it is saying biceps lengthened, go into the dorsal horn, activate the alpha motor neuron for the biceps to get it to contract a little bit more so that I can hold that Coke, not beer, straight up. Okay? So it basically allows us to maintain position regardless of force, theoretically. Of course, we can't always do that. Oh, you guys got this wrong, by the way. This reminds me on the test. I had to throw it out. And you promised you wouldn't. You promised, and I made you guys promise that you would not tell me that it was an axodendritic synapse at the neuromuscular junction. And 75% of you told me that it was an axodendrite. Where the heck is the dendrite? Do you guys remember promising that?
Yeah.
No.
Now we know who's the 25 and who's the 75.
Fingers are crossed.
Because an axon is going to the presynaptic terminal on the other axon to regulate the neuromuscular junction. So it was axo-axonic, but I had to throw it out because you all broke your promise that you would get it, but you didn't get it. But anyhow, this is actually looking at something different, but it just reminded me that I was mad at you. Presynaptic inhibition in this case, well, it's always, but basically we can have, like from your cortex, you can presynaptically inhibit that reflex action. So here's my 1A coming in and activating my alpha motor neuron. I can go from the cortex, right, and send a signal going, chill out, we're not going to let this happen. So I can inhibit my monosynaptic stretch reflex, and that's through presynaptic inhibition. So I can control it. And then this is just another view showing it all. So we've got our muscle spindle, again is our receptor. It's located in parallel with the muscle. It's got two of everything. It's got nuclear chain, nuclear bag, two types of muscle. It's got two afferents, a 1A and a 2. And then it's got two associated efferents, the alpha and the gamma. So what we're looking at here is we've got the afferent information coming in from the muscle spindle saying I'm lengthened, or it's getting lengthened, or it's getting shortened. That information is going to go directly to an alpha motor neuron to contract the muscle that just got lengthened. Okay. It's also, we're going to have gamma motor neuron activation. What's that going to do?
Contract them.
Contract the intrafusal muscle. Why?
To keep it tight.
To keep it tight so it can keep detecting muscle length no matter what. So as I send information from those upper motor neurons, it's not just going to my alpha motor neuron, it's also going to my gamma motor neuron. So I'm sending information to say contract the muscle. I'm also sending information, don't forget, keep my proprioceptors intact so that they can detect that change. So we have simultaneous activation of both alpha and gamma motor neuron to keep it going. And then this is just another view, really. So again, just showing our nuclear chain and nuclear bag fibers, again being in the muscle, and our alpha motor neurons and our gamma motor neurons. We didn't talk about the different types and how they come in. Big thing is it's pretty complex. There's lots of motor neurons going out for different reasons. And remember that there's a lot of interneurons involved and sprouts, so that we don't just get a bicep contraction when we stretch the bicep muscle. We also get a brachialis contraction. We also get inhibition of the triceps. Then we got this other thing, which is actually kind of a self-regulating thing, which is called a Renshaw cell, which is an interneuron in the spinal cord. And as a muscle contracts and contracts, okay, as an alpha motor neuron contracts, it actually sends a sprout to a Renshaw cell, which is in the ventral horn. And its function, it's an inhibitory interneuron, just like almost every interneuron, is to inhibit itself. So why would it do that? Why would I send out the signal to inhibit myself as I contract? So we don't go crazy, essentially. So we don't go crazy. So it's basically saying the more and more I fire, just make sure it dampens the contraction. So it is a self-regulating. So those Renshaw cells are really just regulatory cells for the alpha motor neurons. But it's another cell that's in that spinal cord, essentially inhibiting itself. So that's called Renshaw inhibition. Yep.
So what happens with this, with like muscle twitches and spasms?
With muscle twitches and spasms, they may or may not have anything to do with it, or it may. It might be that it's not inhibiting itself, or it might just be that it is, but just not as much because of the cortical input. So it may or may not be. The point is that we do have a self-regulating mechanism within the motor neuron itself. Well, that the motor neuron itself initiates anyhow. I'm just going to introduce this one, and we'll get into GTOs a little bit more. But so that's the muscle spindle. Remember, actually, we won't even get into GTO. Let's just review, because you guys did so well with cranial nerves. You really didn't. Muscle spindle. What are its two functions? What does it do? What does it detect?
Stretch.
Position sense, which is static position, and then dynamic kinesthesia. And it sort of does do force. We're not going to go, because GTOs are going to be better at force than muscle spindles. But, all right, so we have two functions. And what are the two afferents? Those are efferents. 1A and 2. And then the two efferents, those you got. Alpha and gamma motor neurons. And then, so remember that at this point, the monosynaptic stretch reflex is really just, as far as our clinical test and integrity, it's looking at just a segmental level. Regardless if we're talking about Renshaw cells or reciprocal inhibition, it's all still at that same segmental level. We haven't gotten outside of there yet. All right, so next time we will start talking about the other big proprioceptor, which is our GTOs. All right? Tomorrow I am scheduled, I think, to talk in psychosocial. You guys don't even have any idea. I think I am. That's on my schedule. So